The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Jackie Leiser, and I'm a manager with the CAQH core team. I'd like to welcome you all to today's 2022 CAQH Index webinar. The CAQH Index is celebrating its 10th year of tracking industry progress, and our team is excited to share our key findings with you all this afternoon. Today, you'll be hearing from April Todd, our Chief Policy and Research Officer, Christine Bernaska, our Director of Research and Measurement, and Anna Simon, our Senior Health Policy and Data Analyst. Before I pass things over to April to get us started, I'm just going to run through a few logistics with you all. First, today's session will be recorded, and we'll send out the recording after this presentation within the next 1 to 2 business days, along with a copy of our slides. Your phones will be muted during the webinar. And throughout this session, if you want to ask our speakers any questions, you can do so in that question panel on the right-hand side of your screen. Questions about CAQH tools and applications can be directed to CAQH via the questions panel. And with that, I'm going to go ahead and turn it over to April to go through our agenda.
Thank you, Jackie. Good afternoon, everyone, and welcome to our 10th anniversary index webinar. We are very excited to have you on the call today, and very excited and proud of the work that we've done over the past 10 years, and looking to share information with you both from our most recent survey year as well as some trends over the past 10 years. But first, I want to give a brief overview of the index, what it tracks, how it has changed over time, before we head into some key findings from this past year, the second year of during COVID. So some interesting trends that we have noticed over the past couple of years. We'll dive deep into the transaction findings themselves and some of the trends we are seeing there, and end with a call to action before we open it up for questions, as we're very interested to see what questions you all will have. Next slide, please. So first, a brief overview of what the CAQH Index is. Over the past 10 years, the CAQH Index has focused on tracking the adoption of administrative transactions, as well as the cost and time to conduct those transactions and the volume of the transactions within the industry. We also, over time, have added estimates of national spending, as well as cost avoided on an annual basis from the transition from manual to electronic or automated processes. And this is a national benchmarking survey. We survey the industry and we make estimates at a national level on all of those areas that I had mentioned. And really, we hope the industry uses this as a tool to track and monitor progress, as well as to identify areas where we have made success, as well as areas where additional effort is needed within the industry to make further savings in administrative areas. This is a collaborative initiative. We work with an expert advisory council that represents providers, health plans, standards development organizations, vendors, and other industry partners and experts. Want to really thank our Index Advisory Council for all of the expertise that they have provided over the years. In fact, we have a number of council members who have been with us for the entire 10 years of the index, and in particular, really want to thank those individuals who have dedicated their time and effort to really providing the industry with a valuable tool for monitoring progress. So on the next slide, I want to talk a little bit about what is tracked in the index. Over the past 10 years, really what the index is tracking is the full administrative workflow. And what this includes is tracking from when a visit is scheduled to when a patient has a visit, whether there are referrals or prior authorizations needed for care, all the way through claim submission and payment. And so covers that entire administrative workflow. And over time, and what we've seen in the most recent years, is there may be additional components of this workflow that have been added and that we have asked about. For example, things related to value-based payment and provider attribution. We've asked about those topics, as well as new topics related to the use of FHIR APIs and making that information available to patients. Next slide, please. As I just mentioned, Over time, in addition to our standard metrics that look at the workflow, the administrative workflow, over time we have looked at a variety of different metrics and added supplemental questions. This particular year, this is the first year that we have added specific metrics around cost and time and volume and adoption for two new required APIs that are under the CMS interoperability role, and that is the patient access and provider directory APIs. We have also added questions this year around some pharmacy transactions for medical providers in particular. We will not be reporting on these particular metrics today, but please look in the future for issue briefs that we will be releasing on these topics. In addition to those ongoing metrics that we have added to the index, we also have one-time supplemental questions that we've added this year. These are questions that change from year to year based on topics of interest within the industry. The first set of questions that we have added is around delegated and benefit management vendors and the use of those vendors, exchange mechanisms, volume, what those vendors are used for. We have also added some questions for providers in particular related to good faith estimates under the No Surprises Act to ask about exchange mechanisms, some questions around volume, cost, and time to really get a sense for how providers are thinking about these things and what their experience has been. Again, you will not see results on these questions in the webinar today, but please look forward to issue briefs that we will be releasing in the near future related to these topics. Next question, slide, please. So you will see a few and hear a few terms that we will use throughout the afternoon. So wanted to make sure we were clear on what those definitions mean. So first, you will hear a lot around costs and transaction costs and what that means. When we are reporting out costs and savings and spend, that is really referring to the actual time and labor it takes to conduct a transaction. Costs related to systems implementation or any pre or post work are not included in these estimates. It is just to conduct the transaction itself, whether it be electronic, partial, or manual, as you will see for definitions later on this slide. An electronic transaction are transactions that are conducted using the HIPAA required standard. Where there is not a standard yet specified, specifically, for example, for attachments, we define electronic as those transactions most commonly used within the industry, such as the X12275 and the HL7 CCDA. A partially electronic transaction, these are transactions that are using web portals or IVR systems. And then lastly, manual transactions are those that are requiring end-to-end human interaction, such as the use of telephone, fax, and or mail. Next, please. Some additional metrics that we will discuss today, more on the financial side. So the first is cost savings opportunity. And what cost savings opportunity means is the savings that occurs from switching from a manual or electronic process to a fully electronic process. The cost differential between those two modes of engagement. We also will talk about estimated spend. This is the spend that we estimate at a national level that is spent by medical and dental plans and providers on exchanging a transaction. We look at the spend in total, as well as by mode, so by that electronic spend, partial electronic spend, and manual spend. The electronic spend, that in our slides is really the minimum necessary cost to conduct a transaction, and we compare that to cost avoided. The cost avoided, how that is calculated, is if we had assumed that all of the volume of transactions were conducted manually, what is the difference between that versus what is occurring today with the cost of those transactions being conducted electronically? That is the cost that has been avoided by the industry. Next slide, please. Today, what you will see in terms of the webinar and the transactions that we are reporting on, we have 9 medical transactions and 8 dental transactions that we will be reporting on today, as well as some historic trends with those transactions. Information around our data collection effort. Every year with the index, our timeframe for data collection for both plans and providers runs from the end of June to the middle of September. And this timeframe is really important because it allows for a 6-month claim runout from the prior year to make sure that we have the full volume of transactions that had occurred in the prior year. So the data that we are reporting on today is from the entire year of 2021, the second year during the COVID timeframe. What's covered in the index is transactions that are represented from health plans that represent 60% of covered lives in the US for medical plans and 48% of covered lives for dental plans. We also had a very significant provider response this year, increased by more than 50%. Really want to thank our providers out there for taking the time out of their very busy days to make sure that we are getting good responses to the survey. The number of transactions that's reported by the index for the medical industry, over 14 billion transactions and 828 million transactions for dental. As I mentioned, these results are weighted up to national volumes, so we will see much larger volumes estimated in the slides to come. And as I've already mentioned, this reports on 9 medical, 8 dental transactions, and a number of different enhancements and supplemental questions we've asked over the years. And lastly here, as I wrap up on our overview, wanted to highlight a few areas of progress that we have had over the years. Over the last 10 years of the index, we have consistently increased the representation within the industry. Today, the transactions that you are seeing represent over 200 million members. That's over 60% of covered lives in the US, so very significant participation from the plans. A number of these plans have participated every 10 years of the index. So really a lot of commitment there from the health plans to submit this information. Over the past 10 years, we have seen some pretty significant growth in automation. For eligibility and benefit verification, it's grown by 25 percentage points over the past 10 years. That's a significant savings for the industry. Similar for coordination of benefits, a 42 percentage point increase in that area. And although for prior authorization, it's one of the lowest adopted electronic transactions within the industry, it has quadrupled in its electronic adoption over the past 10 years. So there's definitely some improvement there, but much more to go. And so the savings that the industry has seen from this automation, $187 billion annually from this automation within the industry. That is very significant volume of cost. Over the years, we've been proud to be able to have enhanced reporting throughout the index, and this really has been from the sample size that has grown from plans and providers to allow us to do additional metrics and add additional content. So we have tracked cost avoided, we've added spend, we've added pharmacy transactions, asked about FHIR APIs. We've also been able to ask about timely topics related to the introduction of FHIR and the readiness of that. Started to ask about value-based care and provider attribution. Specifically over the past couple of years, asked about the impact of COVID and how that has really changed our industry and how they address things. Looking at both clinical and administrative workflow, how that is changing, as well as some new regulations that are impacting how providers engage, like with good faith estimates. So very proud to have been able to track these timely questions with the index. And so with that, want to get into some key findings. I'm going to turn it over to Christine Berdanska.
Great. Thanks, April, and to everyone for joining the call today. I'm now going to share the 2022 key findings with you. As we review these findings, keep in mind the data is from the second year of COVID, which is 2021. During this year, we saw COVID cases and admissions decline and healthcare utilization increase. Automated processes that were implemented during the first year of COVID to support remote work continued as use of electronic transactions rose. Staffing shortages during the pandemic brought on by burnout, however, increased salaries as medical facilities were forced to pay more to attract and retain workers. This countered savings that were achieved from the transition to more automated workflows. Higher salaries impacted costs to complete administrative tasks and overall spend as the number of transactions conducted increased. In several cases, the workforce shortage resulted in less experienced staff being hired, which impacted the time to complete. Instead, we saw that electronic adoption increased or remained stable for all but one medical transaction and all dental transactions. Overall transaction volume increased as social distancing requirements relaxed, appointments were rescheduled, and the COVID vaccine became available. Spending on administrative transactions increased for both industries despite greater automation, as staffing shortages and increased volume impacted the cost and time it took for providers to complete tasks. Similarly, cost savings opportunity for the medical industry increased as transaction volume and provider costs increased. Looking at the dental industry, we saw that the cost savings opportunities remained fairly stable. Next slide. Now I'm going to look at the data. The next few slides present highlights related to adoption levels, transaction volumes, spend, and cost savings opportunity. As we walk through the findings, keep in mind the contextual factors I just mentioned. Start by looking at medical plan adoption. On this slide, you will see that overall adoption increased or remained stable for all transactions with the exception of claim payments, which decreased slightly. For the second year in a row, adoption increased the most for remittance advice at 19 percentage points, followed by claim status inquiries and coordination of benefits, both which increased 4 percentage points. Next slide. Switching to the dental industry, we see that adoption increased for all transactions. Adoption increased the most for attachments at 12 percentage points, followed by remittance advice at 11 percentage points. Claim payments still had the lowest adoption among the dental transactions. It is worth noting that this is the first year we were able to report on adoption of coordination of benefits for the dental industry. Next slide. This slide shows that overall transaction volume increased for the medical and dental industries as utilization rose. Medical volume increased by 28% and dental volume increased by 9%. For both the medical and dental industries, electronic volume accounts for the highest percent of total volume at 82% and 51% respectively. Slide. We see that spending related to administrative transactions increased for the medical and dental industries. Spending on medical administrative transactions increased 47% to $55 billion, and dental spending increased 23% to $5.4 billion. The large increase in spending is due to higher utilization and provider time to complete tasks. For the medical industry, provider time to conduct transactions increased on average 15%, which accounted for more than half of the increase in total spend for most transactions. New staff often required more time to complete tasks. Next slide. We are now going to dive deeper into the medical industry to see what is driving spend. Based on the reported data, the medical industry spent an estimated $55 billion conducting the listed transaction. This amount is up $18 billion from the last report. Of the $55 billion, eligibility and benefit verification continues to account for the greatest portion of the total annual medical spend at 48%, followed by claim submission, which accounts for 20% of the total annual medical spend. Eligibility and benefits can be attributed to a significant increase in overall volume. Volume increased 45% from the previous report due to greater utilization and thus more verifications conducted. noting that the largest increase in spend from last year is for claim submission, which increased 83%. The increase in spend was a result of higher patient encounters and providers spending more time conducting electronic submissions as new staff gained experience with requirements and systems. Focusing on costs avoided, we saw that the medical industry has avoided spending $182 billion through automation, up from $161 billion last year. Next slide. Looking at the dental industry, we see that dental spending increased from $4.4 billion to $5.4 billion. Of the $5.4 billion spent on conducting the listed transactions, similar to the medical industry, eligibility and benefit verification continues to account for the largest portion of the total annual dental spend at 24%. For the dental industry, remittance advice also accounts for 24% of the total annual spend. Two transactions are followed by claim submission and payments, which both account for 18% of the total annual dental spend. I'll note that the largest increase in spend from last year was for remittance advice, which increased 43% due to duplicate postings of information on portals and ERAs. Focusing on costs avoided, we see that the dental industry avoided $4.8 billion through the use of automated processes, which is up from $4.4 billion. Next slide. On this slide, we see that cost savings opportunity continues to increase for the medical industry and remains stable for the dental industry. The cost savings opportunity for the medical industry increased 27% to $22.3 billion. Efficiencies gained via automated processes were countered by increases in costs and volume. For the dental industry, cost savings opportunity remains stable at $2.6 billion. Next slide. We are now going to look more closely at what is driving the cost savings opportunity for the medical industry. There's a lot of data in this table, so I'm going to highlight some key findings for you. Looking at the average cost to conduct each transaction, similar to last year's report, we see that the biggest cost savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. On average, the medical industry could save $13.61 per claim status inquiry by conducting an electronic inquiry as opposed to a manual inquiry via phone, fax, or email. Similarly, the industry could save almost $12 per eligibility and benefit verification by conducting a verification electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the industry $6.54 more to conduct than each electronic transaction. These savings add up. For a single patient encounter, the medical industry could save $52 if all of the reported transactions were conducted electronically. The cost savings opportunity is larger for providers at $35, while plans could save about $17 per patient encounter. There are also cost savings opportunities associated with moving from portal use to fully electronic transactions. On average, the industry could save almost $4 by conducting a remittance advice using the HIPAA standard as opposed to via a portal. Similarly, the industry could save slightly over $3 by conducting a fully electronic claim status inquiry as opposed to one using a portal. Next slide. We are now going to look more closely at what is driving the savings opportunity for the dental industry. This table mimics the table that we saw for the medical industry with just fewer transactions. Looking at the average cost to conduct each transaction, similar to the medical industry, we see that the biggest cost savings opportunity is for claims status inquiry, followed by eligibility and benefit verification. On average, the dental industry could save $10.63 by conducting an electronic inquiry as opposed to a manual inquiry. Similarly, the industry could save almost $9 per eligibility and benefit verification by conducting a verification electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the dental industry $4.31 more than each electronic transaction. And again, these savings add up. And for a single patient encounter, the dental industry could save almost $26 if all of the reported transactions were conducted electronically. Similar to the medical industry, the cost savings opportunity is larger for dental providers at $18.41, while dental plans could save $7.47 per patient encounter. Looking at the cost savings associated with moving from portal use to fully electronic transactions, we saw that on average, the industry could save almost $3 per transaction by conducting a claim status inquiry using the HIPAA standard, as opposed to via a portal. Similarly, the industry could save about $2 by conducting a fully electronic eligibility and benefit check, as opposed to one using a portal. Next slide. In addition to estimating cost savings opportunities, we're also able to estimate time savings by moving from manual to fully electronic transactions. Looking at the medical industry, we found that on average, providers spend 9 more minutes conducting manual transactions compared to electronic transactions. For patients requiring all 7 medical transactions, a provider could save, on average, almost an hour by conducting all the transactions electronically instead of manually. Focusing on the individual transactions, we saw that the highest time savings opportunity is for claim status inquiry. On average, a manual claim status inquiry required 19 minutes to complete, while an electronic inquiry required 4 minutes to complete. Providers could save 15 minutes by conducting an inquiry using the HIPAA standard as opposed to calling, emailing, or faxing. And just as there are cost savings opportunities associated with switching from portals to fully electronic transactions, there are also time savings opportunities. On average, a medical provider could save 18 minutes by conducting the reported transactions using the HIPAA standard as opposed to via a portal. Slide. Moving on to the dental industry, we found that on average, dental providers spend 6 minutes more conducting manual transactions compared to fully electronic transactions. For patients requiring all 5 dental transactions, a provider could save, on average, 31 minutes by conducting the transactions electronically instead of manually. Focusing on the individual transactions, similar to the medical industry, we saw that the highest time savings opportunity is for claim status inquiry. On average, a manual claim status inquiry required 16 minutes to complete, while an electronic inquiry required 3 minutes to complete. Dental providers could save 13 minutes by conducting an inquiry using the HIPAA standard as opposed to calling, emailing, or faxing. By switching from portal use to fully electronic transactions, a dental provider could save, on average, 12 minutes. Well, that concludes my section of the presentation of the key findings. I know I shared a lot of information with you. If you have any questions, please feel free to ask them in the question panel or email us at explorations@caqh.org. I'm now going to turn the presentation over to Anna Simon, the data analyst on the index. She's going to dig deeper into the individual transactions along with the administrative workflow. Anna?
Thanks, Christine, and thanks everyone for joining us today. As Christine mentioned, I'm going to present findings for the transactions studied in this year's index. For each transaction, I will share in adoption and volume, and where possible, provide some context around the findings. So we will start with the eligibility and benefit verification transactions. Next slide. So looking at adoption, we see that adoption increased for both the medical and dental industries. For the medical industry, electronic adoption reached 90%. Looking back over the past 10 years, we see that electronic adoption has actually increased 25 percentage points. For the dental industry, adoption increased 4 percentage points as the use of electronic eligibility verifications continued to be promoted within the dental industry. Since 2018, electronic adoption of the eligibility transaction has increased by nearly 30 percentage points in the dental industry. So this positive movement towards electronic use is partly due to dental plans continuing to encourage the use of electronic transactions, knowing that provider questions related to eligibility and benefits are one of the top reasons for manual inbound phone calls. Next slide. On this slide, you will see that overall volume of eligibility and benefit verification transactions increased for both the medical and dental industries. The medical volume increased 18% as a higher number of medical eligibility verifications were conducted due to higher utilization and the rescheduling of appointments that were previously canceled or postponed due to the pandemic. Additionally, the administration of COVID-19 vaccinations in early 2022 often required an eligibility check to determine who to bill, which drove up the volume. Overall dental volume rebounded to pre-COVID levels as routine dental visits resumed. It's important to note that as volume increased, so did the spend. Spending for the medical eligibility transaction increased almost 50% to $26 billion and remains the highest spend among the transactions, accounting for almost half of the total annual medical spend. Additionally, dental eligibility spend is also one of the highest for this industry, accounting for almost a quarter of the total annual dental spend at around $1 billion. Next slide. Moving on to prior authorization. Next slide, please. So we see that electronic adoption continues to increase for the medical industry. Although electronic adoption remains one of the lowest among the transactions studied after attachments, adoption has increased by 21 percentage points in the past 9 years. Next slide. Looking at the number of prior authorizations conducted, the overall volume increased about 60% as restrictions or waivers placed on prior authorizations to ease administrative burden during the COVID outbreak were lifted. While volume rose for all 3 modes, portal use experienced the largest increase in volume among providers and accounted for almost half of the overall volume. This is a proportion that has increased over the last 3 years. As the volume continues to increase, it's important to note that prior authorizations are still the most time-consuming transaction for providers. It takes providers an additional 11 minutes to process a prior authorization request manually instead of fully automated. Next slide. And next slide. Focusing on claim submission, medical adoption remained stable while the dental industry saw an increase of 2 percentage points to 86% adoption. For both industries, electronic adoption of claim submissions remains one of the highest compared to other transactions. Next slide. On this slide, we see that both medical and dental claim submission volume increased around 20%. For both industries, the increase in volume was driven by an increase in electronic submissions. Generally, volume increased as a result of higher patient encounters after the pandemic. But as the volume increased for both industries, providers ended up spending more time conducting these submissions as newly hired staff gained experience with requirements and systems, which drove up the spend for both industries. Medical claim submission spend had the highest increase out of all transactions and almost doubled to $11 billion. Similarly, the dental industry experienced almost a 50% increase in claim submission spend to nearly $1 billion. Next slide. Attachments is the lowest adopted transaction for the medical industry and third lowest adopted transaction for the dental industry. The electronic adoption remains low for both industries as an electronic standard has yet to be federally mandated by HHS. Plans, providers, and vendors have delayed efforts to create automated solutions without much federal guidance and industry support. And this has led to incomplete solutions and sometimes manual workarounds that may continue today. Next slide. Turning to the number of attachments conducted, we saw that volume decreased slightly for the medical industry as plans reduced the number of supporting documents required during 2021. As volume dropped and adoption increased, so did the medical cost savings opportunity associated with switching from manual to electronic attachments. This was the only decline among the transactions. The lower manual volume and plan costs, coupled with higher adoption, drove the drop in cost savings opportunity. In comparison, the dental industry volume increased almost 50% due to more dental procedures being conducted after the pandemic, which triggered the need for attachments to verify services being requested or billed. Next slide. Moving on to acknowledgements, you will see that for the first time, we are able to trend this transaction for the dental industry. Given that the majority of health plan systems auto-generate a confirmation response after receiving information from a provider or clearinghouse, the plan adoption is 100% for both industries. Next slide. On this slide, you'll see that electronic volume for acknowledgements continues to grow for the medical industry. And as seen here, no manual resources are really needed to complete an acknowledgement. So this is beneficial as the volume continues to rise. Next slide. After dropping slightly last year, medical adoption of coordination of benefits increased to 91% and is among the most automated transactions. Since 2015, COB electronic adoption has increased by 42 percentage points, which is the highest increase for any transaction in the last 10 years. Additionally, for the first time this year, we were able to report on adoption for the dental industry, which is at 52%. Next slide. On this slide, we see that for the medical industry, the overall volume increased 10%. As overall volume increased, the spending on COBs also increased 25% to 65 million. Another factor contributing to the increase in spend, aside from volume, is that manual costs increased as practice staff may have performed additional steps to identify coverage information due to job changes that continued into 2021. Next slide. Moving on to claim status inquiry, the medical industry experienced a 4 percentage point increase in electronic adoption, while the dental industry experienced a 6 percentage point increase. Medical adoption increased after a decrease last year brought on by complicating factors such as new and emerging telemedicine requirements and codes, which had resulted in more manual work for plans and providers. Next slide. So after decreasing in 2021, medical claim status inquiry volume rebounded 56% as utilization increased. The increase in doctor's appointments resulted in more claims being processed, leading to more inquiries conducted. This volume rebounded translated to a 50% increase in spend, which is the second highest increase among the medical transactions. Spending was impacted primarily by the increase in providers using portals to conduct inquiries and the costs that are associated with this. In comparison, volume decreased for the dental industry. This decrease in dental volume occurred after volume had increased the first year of COVID, as dental providers were catching up on outstanding claims early in the pandemic while offices were closed. Next slide. Now moving on to claim payment. Looking at the adoption, we see that electronic adoption declined slightly for the medical industry. This was the only transaction that experienced a decline in adoption. In comparison, the dental industry increased 1 percentage point. Next slide. Looking at the claim payment volume, there was considerable decrease in volume for the medical industry after a substantial increase last year as providers reconciled late payments during low utilization. The large decrease in volume is due in part to the inflated number of payments that were processed during the first year of COVID. In comparison, the dental industry experienced an increase in volume as a result of higher utilization after the pandemic. The increase was driven by the greater use of EFTs, which is an ongoing industry push. Despite the decrease in volume, medical providers spent more time processing manual payments, which increased the cost. Similarly, dental spending increased as the time and the cost to conduct manual payments rose for dental providers. Next slide. And lastly, we will talk about remittance advice, the final transaction in the administrative workflow. On this slide, we see that for the medical industry, adoption of electronic remittance advice increased 20 percentage points. This is the highest increase among the transactions. For the dental industry, remittance advice experienced the second highest increase in electronic adoption at 11 percentage points. And looking back at the last 10 years, it's important to note that the electronic adoption of remittance advice has increased 40 percentage points for the medical industry and 23 percentage points for the dental industry. Next slide. When looking at the volume of remittances conducted, we see that the medical volume decreased 25% as the practice of posting duplicate remittance advices on health plan portals and through ERAs seems to be declining. This is evident by the large decrease in portal use, which is slightly over 50%. While volume declined for the medical industry, it didn't translate to lower spending since newly hired medical providers or staff may have spent more time accessing information, resulting in increased costs, which drove the medical spend to almost $6 billion. Unlike the medical industry, the dental industry appeared to be posting duplicate remittance advices as portal and ERA use increased. In some cases, duplicate postings can offer dental providers various opportunities to access payment information, which could explain the increase. And due to the spike in volume, the costs associated with dental remittance advice also increased and accounted for 24% of the total annual dental spend. This is the highest spend along with the eligibility and benefit transaction. Next slide. And this concludes my discussion of the findings related to the transactions studied in the index. For more information on the individual transactions, I encourage you to look at the 2022 Index Report, which is posted on our CAQH Explorations website. I will now turn the presentation back to April to talk about actions that the industry can consider to help maintain and improve on the achievements that we've just discussed. April?
Thank you, Anna. So before we get into some questions, and we're already getting a number of them coming in here, so I'd encourage you all, we will have some time, please submit in some questions you have. Wanted to talk a little bit about some suggestions for the industry to take in reaction to some of these findings. I think the first one is to really we've identified through the index areas where it is pretty clear there are significant opportunities for savings. There are also significant opportunities to reduce time and burden for providers as well. And so there are definitely areas there to focus on to reduce cost and time, and to really kind of understand what is happening with those processes, and to in particular identify and address the pain points and challenges. Transactions are only as good as they are updated. And so continuing to identify those will continue to help to address further areas where the transactions can be more standardized. The second area is really a focus on training. I think what you have read and heard today is that the industry has made significant progress, particularly during the pandemic, in automating a number of transactions, particularly as people have had to adapt to a new environment, working from home, and taking that as an opportunity to automate. However, we've also had an interesting shift in our workforce and in staffing. And a number of people have retired, have left the medical industry. We have new folks that have joined, and we have gaps in staffing where providers are doing some of these transactions themselves. And so, there really is a need for a focus on training right now to help get this workforce up to speed, help them become more efficient, and get those costs down. So at this particular point in time, that appears to be a real need in the industry is around training. And then lastly is around adapting to changing business needs. As I said before, the transactions are only good as they respond to business needs. And particularly during the pandemic, we have seen a lot of new needs come up. Telemedicine is one of them that, there wasn't a lot of telemedicine before the pandemic. Now there is a lot of telemedicine, and our transactions historically did not accommodate that well, and the industry is adapting. But the industry is also, changing more quickly. And so as an industry, we need to have more frequent and routine updates to our business transactions so that they are accommodating the needs within the industry, so that we can keep things automated and not have to put those unique needs, move them to manual processes. So in terms of a call to action, those are the areas that we see next year or this year, and look forward to tracking into future years. with that, I'm going to hand it over to Jackie, who can help remind folks how to submit in questions.
Great, thanks, April. And thank you all, April, Christine, Anna, for those awesome insights on the 2022 CAQH Index. Like April mentioned, we do have a bit of time for questions, so thank you to those of you who went ahead and submitted throughout the presentation. As a reminder, if you still want to submit a question, you can do so by looking at that right-hand menu on your screen and submitting them under the questions panel. And with that, I think we'll start taking a few.
Okay, so I'm going to combine a couple of questions here that are a little similar. So Christine, one of the questions is around eligibility and benefits. So generally the question is, at 90% adoption, what types of eligibility verifications are still being done over the phone? Is it that payers aren't maybe offering the transaction? Is it that providers aren't using it, or some other reason? What's going on with eligibility?
Yeah, no, that's a great question. And what we have found from talking with plans and providers is there's still a lot of manual work, specifically calls being made between plans and providers due to these complex benefit designs and the varying benefits, tiered benefits that plans offer, and providers wanting to clarify and better understand these plans. And then also, as you had mentioned, there's been a great rise in telemedicine. And so that was something new for plans, providers, as well as patients. And so a lot of phone calls and plans and providers working together to understand the requirements, the codes, and what is needed for telemedicine visits.
We're also getting a number of questions in around prior authorization. So I'm going to start off with the first one here. There's a few of them. So question is, what is holding back the adoption of electronic prior authorizations? I can take that one, and I'll give you the next one on the list here for prior authorization. I'd say there's a couple of things with prior authorization. As opposed to the other administrative transactions that we track, prior authorization is a little unique because it involves both administrative systems and clinical systems, particularly on the provider side. And so anytime you're combining systems, that gets a little more challenging. It's not just the request, but it's also sending that image, sending that test, and knowing what to send. And so it has made prior authorization a little more challenging to do as compared to some of the other transactions. And related to that, as you heard us talking about earlier, one of the things that has really held up automation of prior authorization is that one piece of that workflow does not have a standard. And so under HIPAA prior authorization, there is a standard for the request. There is not a standard for how to submit the documentation that often needs to go with the prior authorization, which is called an attachment. And so actually just this last December, HHS has proposed a standard for attachments. I would encourage all of the industry to read up on that and to submit comments. They're due the middle of March around the attachment standard. And so that really has held up automation of prior authorization because there isn't a standard. Vendors and health plans and others are less likely to put in an electronic way to submit attachments without having a standard, so that they're not implementing something that they might have to change and have wasted spend on to change that. And so we're really hopeful with an adopted mandated standard from HHS coming forward here, hopefully within the next soon, that will help to improve electronic adoption, not only of attachments, but also of prior authorizations. They are very much linked together. So the second question we have here around prior authorization, Christine, I'm going to send your way, is have you considered tracking prior authorization for dental?
Yeah, great question. We have, and we do. So we have worked with our council members and specifically the ADA to focus on predetermination for the dental industry. And so while we have collected that information over the last 5-6 years, we have not received enough information to report out on it. So either plans providers are unable to report on it, they don't track it, it's unclear. But yes, we are tracking it, and we do hope as the sample size increases and we tend to get more robust data year over year that we will eventually be able to report out on that metric.
There's another question here around prior authorization. I think I answered it, but I'll just address this more specifically. There's a question around when do you expect CMS or ONC to have electronic support for attachments? And as I mentioned before, there is a proposed rule that is out from CMS right now. It went out in December, and comments are due back in March, middle of March. Typically, how that process has historically worked, although the timing may be a little different, is that once CMS receives comments from that, they will consider that internally, make any adjustments to the rules, and put out then a final rule that could come out anywhere from a few months to a few more months to come out with that. Once a final rule is out, the industry has 2 years under HIPAA to be able to implement that. And so that's generally the time frame that we are anticipating related to that. Christine, a question here around behavioral health. Is behavioral health billing included in any of our in medical results?
So yes, that is included in the medical results when we conduct our analyses. Question.
There is a question here around spend. Is the increase in spend this year an outlier, or do you expect it likely to continue? I can maybe start on that, and
Sure.
Christine, if you have anything to add there. Essentially, yes and no. It's not an easy answer to that question.
No.
One, for the part of the spend increase that's related to utilization, I would expect that this year is a bit of an outlier because during the first year of COVID, people weren't going into the doctor, and there was a lot of pent up demand going into the second year. So utilization is up across the board. Actually, all the transaction volume is up across the board. So that has a considerable impact on spend. The other thing, though, that will be interesting to track, and it's just really hard to know where this is going, is the impact of staffing and the workforce issues we have going on right now. That could potentially ebb over time, but just given the low unemployment rate we have right now and kind of the staffing difficulties, it will be interesting to watch this over the next couple of years to see where that staffing piece goes. I don't know, Christine, if you have anything to add on.
No, I was just going to say, when you mentioned in the industry call to action, the training, I think as we see, if plans and providers start upskilling their staff and training them, and staff become more comfortable with the technology, the requirements, the systems, I would hope that spending, or at least time to conduct these transactions, will decrease, which would ultimately impact the spend. But to your point, I think it's very difficult to say right now what will happen related to staffing.
Another question here, and we're getting in a number of questions. We're not going to get to all of them today, but we will definitely kind of combine them into categories, and we can post some of these on our website. Christine, another one here, I had mentioned earlier on about that we had added some FHIR transactions to track this year. Some folks are just wondering if we could talk a little bit more about what it is we're collecting.
Sure. So we have begun tracking, similar to what we do for the other transactions, questions related to volume, as well as cost and time. And specifically, we asked about the provider directory API, as well as the patient access API. And I can see expanding that list over time as FHIR becomes more prominent, and we see that more APIs are required or mentioned within some of the regulation coming up. And as you had mentioned, just to say once again, we will be reporting out on that data in an issue brief or a blog of sorts this coming year.
And Jackie, I think we are coming up at time. As I mentioned before, we do have more questions in here than we are able to answer right now, but we will definitely compile those and post them on our website. So if you continue to have questions, please submit them in through us, or also through our email box as well, and we are happy to answer those.
Great. And I think just lastly, on this last slide, if you do want to access the full 2022 CAQH Index Report, you can find that at www.caqhindex.org. And we will also be posting a recording of this webinar on the website and emailing it out to everyone who registered. So thank you all so much for joining us this afternoon, and have a great rest of your day.